بدأ الليكشر مش الليكشر البناء بتاعه الويبينار.
Good morning, colleagues. Can you please mute your mics? Colleagues, can you please mute your mics?
Hello.
Good morning, everybody. Can you please mute your mics? We are going to start in 1 minute.
Hello.
Dr. Firas, good morning.
Good morning. سامعيني كويس؟
Yes, we can hear you very well. So good morning, everybody. It is 10 o'clock now, and we are going to start our webinar on cessation services are essential health services. I thank you all for joining our webinar, and I thank all the speakers for accepting to present today in this webinar. We will start our webinar with Dr. Asmus Hemmerich. I cannot see Asmus. Yes, I can see Asmus. So Dr. Asmus, the floor is yours to introduce this webinar, the objectives, the aims, and the expected outcomes to all participants. Please start.
Yes, good morning, Fatima. Good morning, colleagues around the region and beyond. And I'm very happy to be with you today and to welcome you on behalf of the WHO Eastern Mediterranean Office here in Cairo, Egypt, where Fatima is part of our department, of course, for non-communicable diseases and mental health. And of course, tobacco control is a very, very important part of our work. And hence, I'm very happy to be with you today to just introduce to the objectives of this meeting, which are basically threefold. One, to highlight the importance of the availability, accessibility, and also the policy measures around tobacco and nicotine cessation services, which we are focusing on today. Number two, to present best practices, and I believe that's very important indeed, and we can do that very well today, and discuss the current status of cessation services in our region, the Eastern Mediterranean region. And number three, to discuss and agree with participating countries on a way forward on cessation, particularly considering the situation under COVID-19. Fatima, can you kindly show my slides from your end, please?
Yes, I can. Give me 1 second, please. Colleagues, can you please make sure that your mics are muted? Can all participants, apart from the person speaking, mute the mics, please?
Perfect. So you can go straight to the not the next, but the slide after the next, please. With the lovely picture of the young people. No, that's not my presentation, I believe.
This is not Asmus' presentation. This is my presentation, Sophia. Sophia, this is not Asmus' presentation. This is my presentation. Give us 1 second.
All right,
please,
I apologize. We are just trying to get the right slides on screen whilst everyone's settling in. Okay, yes, this is the right slide. If we can do this on slideshow, perfect. Okay, right. So we're talking about the importance of the cessation program that has been promoted by tobacco control advocates for years now, and it has been very much highlighted in the WHO latest global report on the tobacco epidemic, released only in July last year, where the chapter O to offer help to quit has been particularly investigated in much detail, and I can really recommend to all of you this report, which is online, of course. And it has been then put into perspective by our global NCD Essential Services survey during COVID-19 times earlier this year, that revealed the status of the policy during the pandemic. And the picture doesn't look very encouraging at the moment. Next slide, please, Sophia. Yes, so which are the key elements of this part of the Empower framework, offer help to quit? Well, in the new report, the global report from last year, has a strong focus on integrating care, both preventive and in a way also providing services at primary healthcare level, very importantly. A renewed focus on, of course, nicotine replacement therapy, but also the establishment of a free quit line. And additionally, continued training for medical professionals. Next slide, please. If I can ask other speakers, please, to mute your microphone for the time being. Thank you. And Sophia, if you can just move to the next slide, please. Right, so let's look a little bit at the evidence. And these graphs are extracted, of course, from WHO global documents, where we look at the the components of the Empower package with a particular interest in cessation programs. And here we're looking at a period of 12 years, of course, from 27 to 2018, where there has been an increase, a sizable increase of cessation programs around the world. And that is the good news. Next slide, please, Sophia. However, if we now look at only the last 3 years out of that 12-year period, the picture looks quite different. And what we see is actually a -1% decrease in global cessation programs over that period of the last 3 years. So it shows there has been a global kind of slowdown of tobacco cessation programs, and that's very worrying. Next slide, please. So let's look a little bit more closely also at our region. I mean, first of all, I think on the left, we still have global figures basically showing a relatively flattening of of cessation measures around the world over that period of 12 years. And then if we look at the map on the right, we see that there's a lot of gray and very little blue in terms of country colors, meaning that very few countries in our region have actually significantly increased cessation programs. And when we look at the details, as stated at the bottom of the slide, there's only 3 countries really with a dynamic level of cessation policy implementation. And those countries are Saudi Arabia, Kuwait, and the United Arab Emirates. And they're in blue color on that slide. Next slide, please. Now, this is bringing us into 2020, the COVID times. And here, unfortunately, and I believe that's from the survey that we have done globally, we see that only that less than 50%, in fact 42% of the 22 countries and territories in our region are currently considering cessation services with priority, I think we should say. So there's a real threat that, interestingly, despite the fact that COVID is a respiratory disease, governments are not necessarily prioritizing cessation services at the moment. Next and last slide, please. So what that means is, of course, that there's a very good reason that we are discussing amongst colleagues and experts, especially from countries in EMRO, what more can be done, needs to be done. And we believe that we can get out of this consultation a lot today. Number one, to really, build this consensus on what needs to be done in terms of strengthening tobacco cessation services in our region. Number two, to discuss how to expand availability, quality, and monitoring of services. And there's a lot of interesting examples available. And number three, finally, to focus also on exploring alternative modalities to provide tobacco cessation services under the given circumstances that we all suffer from, I may say, with COVID. And I believe there's some very interesting ideas, and there's always opportunities when we face threats. And I personally believe we have great opportunities to scale up cessation, to scale up tobacco control measures in the light of the current COVID pandemic. And I very much look forward to this meeting and look forward to your contributions. Thank you so much. Over to you, Fatma.
Thank you, Asmus, very much for this introduction to the webinar. And I start again by welcoming all the new participants who joined us. We started with 29, we are now 47. And I see that there are 14 people waiting in the waiting room to join us. So welcome all of you. Today, I am your host together with my colleagues from the EMRO region to discuss cessation services, what needs to be done, what are the gaps. I have two requests for all participants. Please close the camera so that we can improve the connection. And second, please mute your mic all the time. Only speakers will be able to speak during this webinar. And if you have questions, please send them to the chat room where my colleague, Dr. Randa Abu Naga, is with us today to coordinate the discussion. We have today 5 speakers. We have Dr. Dong Bu, who is the specialist in cessation services, leading all the activities at the global level and supporting all regional levels. Dr. Dong Bu Fu, and we have myself will present on the EMRO region. We have Dr. Hiba Fuad, our surveillance officer in the EMRO region, who is supporting all countries to conduct their surveys related to tobacco and NCDs. We have from Qatar, Dr. Ahmed Al Mulla, who is senior advisor to Her Excellency Minister of Health and head of the Cessation Center there and WHO Collaborating Center, who will present to us on the Qatar experience during COVID-19. And finally, we have Dr. Firas Hawari, who is one of the great experts in the region in the area of cessation. Most of you have been trained by Dr. Firas on cessation and different aspects of tobacco control. So I welcome all speakers who I see on the screen with us now. And again, I ask all of you to turn off your cameras, please. Please turn off your cameras so that to improve the connection. We move now to the second presentation today, and this is Dr. Dong Bu Fu. Dong Bu, the floor is yours, and you can share your screen. Please go ahead.
Thank you, Fatima. Good morning, everyone. Can you hear me?
Yes, we can hear you very well.
Let me try to share my screen.
If you want, we can share it from our side.
Hello,
So
everybody. Can you
can
hear me?
start. Yes, you were muted. Now you
Okay,
can
great.
start. Please go
Okay,
ahead.
great. Thank you. Thank you again. And it's a great pleasure to be with you here today to discuss the very important topic during this COVID-19 pandemic. That is the importance of promoting tobacco cessation. So why promoting tobacco cessation is important? The first reason is because we have a very high need for tobacco cessation support in the world. So I give you some figures. According to more than 30 countries' global adult tobacco survey data, we found out that over 60% of the tobacco users actually have an intention to quit. But on the other hand, 70% of them actually have no access to appropriate tobacco cessation services. I think you can see this is the picture is very clear. We have a very high demand for tobacco cessation support. In other words, we have large number of tobacco users waiting for the support. That is very important. The second reason why it is important to promote tobacco cessation is because this kind of intervention or cessation support actually can help smokers to quit successfully, can actually more than double the chance of successfully quitting. So let me also give you some figures. So we all know without cessation assistance, only around 4% of attempts to quit tobacco will succeed. But if they receive behavior interventions and or pharmacological interventions, their chance of quitting successfully will more than double. So in terms of absolute quit rate, you can see here, I will show you I cannot move the slides.
The slides are not changing. Yes, they are not changing.
Yeah, I cannot move the slides. I'm not sure why. Can
click on the mouse. Okay, if you cannot, okay. Sophia will take over. So please don't worry about it. Just tell her
this
next.
is the first slide. It's like 60% of them want to quit, you have intention to quit, but 70% have no access to cessation services. Now, this is the one I just mentioned. For example, if tobacco users receiving the behavior interventions like brief advice from physicians, like the cessation intervention delivered through text messaging or the telephone counseling, their chance of quitting successfully will double. Their absolute quit rate will increase around 2 to 6%. Okay. This is compared to they receive no support. And then if they have chance to receive pharmacological interventions, the increase in the absolute quit rate can be even higher. It's around 6 to 15%. So this kind of next slide, please. So this kind of interventions, I think we are all familiar with. They are nicotine replacement therapy, bupropion, or varenicline. So many of them actually are available in the countries in this region. And then because cessation support can actually help smokers to quit. Next slide, please. And also we all know once people quit, they will have immediate and long-term health and economic benefits. So I think this will be very easy for us to understand. If we provide strong cessation services, can help us save lives, improve health, and save money. So here I show you also some evidence. Evidence shows that it is never too late for tobacco users to quit. For example, if they quit at the age of 30 years old, they will actually add up to 10 years of life expectancy. If they even quit at the age of 50, they will gain like 6 years of life expectancy. And in terms of the benefits of financial benefits, there's one study in Denmark. It shows for those smokers who quit at the age of 35, their total life year health cost save could be 25,000 euro to 35,000 euro. So it's very clear there are benefits in terms of health and financial benefits for us to provide strong cessation services. Because the cessation services can save lives, can improve health, can save money. So WHO recommends, please, next slide, please. WHO recommends tobacco cessation services should be essential health services. For example, in WHO PAN package, tobacco cessation is recommended as one of the essential NCD interventions in primary care. And in the updated Appendix 3 of the Global NCD Action Plan 2013-2020, WHO recommends 3 population-wide tobacco cessation approaches as cost-effective NCD interventions. The 3 approaches are, Dr. Asmas already also mentioned, briefed-wise in healthcare system, national toll-free lines, and cessation. Cessation means cessation interventions delivered via mobile text messaging. And the WHO also recommends, because these 3 population-wide approaches are essential interventions, WHO recommends all the countries should consider prioritize these 3 population-wide approaches in order to reach as many tobacco users as possible at the lowest available resources and have the maximum impact at country level, because resources are always limited. Okay, next slide, please. This year, because the COVID-19 pandemic, we all know, have significant impact on health services, including tobacco cessation services. In many, many countries, tobacco cessation services have been partially or completely disrupted. But on the other hand, we also see many countries actually use the alternative or innovative way to sustain their cessation services during the COVID-19 pandemic. For example, in Thailand, their national quit line asked the counselors to provide counseling service from home instead of asking them coming to the call centers to provide service because the social distance practices. Several countries like Trinidad and Tobago, after their COVID-19 situation under the control, they converted the COVID-19 helpline into a national toll-free quit line. So this is also a very great example. The United States, their quit line even like provide one new service to smokers during the COVID-19 pandemic. Their quit line actually provides free nicotine patches for the eligible smokers who called helpline. So these are the 3 examples. In the Eastern Mediterranean region, we also have many countries have done many good things or have very good examples. Like several countries like Qatar and Jordan, they have great experience to share. I will leave our experts from these 2 countries share their experience with you. Okay. The last part I'd like to share with you, in order to support the countries to promote their population-wide tobacco cessation interventions, which we just mentioned. Next slide, please. We have developed a series of technical resources and tools to support the countries. They could be technical guidance or training packages or online training courses. So because the time limit, I won't read them for you, but they are all available on WHO website. I'd just like to highlight one new tool developed this year during the COVID-19 pandemic. Next slide, please. The new tool actually is a digital health worker we call Florence. So Florence is developed this year and launched by our DG on 10th of July. So who is Florence? Florence actually is a WHO digital health workers programmed to provide brief advice during the COVID-19. Florence actually was developed mainly to help tobacco users to overcome the COVID-19's disruption of tobacco cessation services, because many tobacco users actually have no access to a healthcare system because the situation in the country. But this online tool actually is accessible to everybody. So the Florence can actually speak with tobacco users and provide brief tobacco cessation advice, also refer to any existing digital tobacco cessation service in the country. For example, if your country have a toll-free quit line, if your country have an cessation project like Tunisia, so Florence actually can refer tobacco users to these existing digital cessation services. Florence will speak 6 official UN languages. Currently is only in English version available. The Arabic version of Florence will be available in October this year. So in summary, WHO have developed a series of technical tools and resources. We are ready to support any country to promote tobacco services together with regional country office colleagues. That's all I would like to share with you. Thank you very much.
Thank you very much, Dongbu, for your presentation and for introducing Florence to all the participants. I am sure some of them haven't met her before. Florence is a very interactive person. I myself talked to her online. So you can go online and you can start your conversation with her. And by the way, we have sent to most of the countries that have good cessation services, and we included their information in the Florence system. So she can refer participants from different countries to their own national systems of cessation and direct them to it. So please be encouraged to use Florence and give us feedback, give Dongbu feedback on how you see Florence effective and what gaps do you feel that needs to be bridged in Florence. So now we move to my presentation, and I will speak very briefly on the situation of the regional situation of cessation. So allow me just a few seconds to share my screen. Can you see my screen now? Sophia, is my screen clear?
Yes, it is clear. Just if you could kindly yes, perfect.
Yes, okay. Thank you very much. My presentation is divided into two parts. The first part will focus on cessation services in general in the region. The second part will focus on cessation services during COVID-19 times. And then I will conclude with the recommendations and way forward. As you know, under the global monitoring framework of NCD, we have 9 voluntary targets. One of them is to reduce tobacco control 30% relative reduction in the prevalence of current tobacco use. Are we going to achieve this reduction in the Eastern Mediterranean region? As you can see, these are the 3 trend reports of 2015, 2018, and 2019. In 2015, our region was increasing. This is the red line. You see it is increasing. The second trend report was showing also that we are slightly increasing. This is the green line. And the third report of 2019 came with good news for the EMRO region, that for the first time it indicated that EMRO will decrease in prevalence. But nonetheless, we unfortunately will not achieve the target of 30% reduction in 2025. Only one country will achieve the target in the Eastern Mediterranean region, and this is Pakistan. For us to achieve the target, what do we need to do? We need to implement the WHO, FCTC, and the Empower measures. The Empower measures are 6 measures that WHO developed and launched in 2008, including the most successful and the impactful policies that will really reduce tobacco prevalence around the world. One of them is under Article 14 of the FCTC, and this is cessation, offer, help to quit tobacco use. And the indicators under this has been explained by Dongbu and Dr. Asmus, so I don't need to go through it again. When you look at the cessation services status in the Eastern Mediterranean region, when you look at the number O in my slide, this is the traffic light slide. It shows the status of the policies in different countries of the region. We see under O that there are only 3 countries that achieved the highest level in the policy. Although this is a very simple, straightforward, cost-effective policy. And the elements are only 3 for any country to achieve the policies. But unfortunately, we have only 3 countries that achieve the highest level. These are Kuwait, Saudi Arabia, and United Arab Emirates. The rest of the countries, the majority of the countries are in the middle achievement level. And this means that they are missing one of the elements. When you analyze the elements missing in our region, you see that there are mainly 2. The quit line and nicotine replacement therapy available for the public. So we need to work on this to improve it. However, COVID-19 came to EMRO with potential in improving tobacco control in some aspects. What is this? 17 member states, due to COVID-19, banned water pipe use in public places. That was a direct reaction from governments to the threat of tobacco use and the threat of transmitting the disease through water pipe device sharing, etc., etc. To sustain this, we need to encourage and strengthen 3 other elements around this important policy of banning water pipe use in public places, and also strengthening banning of tobacco use in public places in general. To strengthen cessation, we need first to strengthen cessation, to make sure that there are awareness campaigns at national level that encourage people to quit and to commit to the ban of water pipe. We need to ensure that there is enforcement and implementation. If we look at the cessation services during COVID-19, the NCD Essential Services Survey came to us with a surprise. And you can see on the right-hand side that only 42 of our member states included cessation in their essential health services during COVID-19. Unfortunately, many of the activities that were planned this year in different countries of the region were postponed due to many reasons. And some of the activities that were postponed that included cessation is implementation of the PAIN package, implementation of the hard technical package, mass communication campaigns. All these activities included under it cessation services, and unfortunately it was postponed during COVID-19. If you look at the reasons why this was postponed and why the services were disrupted in the EMRO region, there are many, but some of them contribute directly to the decrease in cessation services. This is some of them are closure of outpatient NCD services, a decrease in outpatient volume, insufficient staff to provide services, NCD-related clinical staff deployed to provide COVID-19, and the public transportation were not as functioning as usual during COVID-19 due to lockdown, etc., etc. So many of these elements also contribute to the reduction in the implementation of cessation services, and including cessation services. Some countries implemented strategies to mitigate the disruption of the cessation services and NCD essential health services in general. In the EMRO region, you can see that some of them applied telemedicine mechanisms, task shifting and role delegation, redirection of patients with NCDs to alternative healthcare facilities. And I think these three elements do contribute directly to future encouragement and increasing of cessation services in the Eastern Mediterranean region. So what are the lessons learned from the COVID experience in particular and cessation services related to this period? We need to assess the capacity of cessation services in the region, and we need to strengthen cessation services with different modality. We need to have alternatives at the same time. We don't say that we have face-to-face, so we don't need to have the virtual. I think one of the lessons learned is that we need to have all the modalities available for countries. We need to encourage remote cessation services, activate mobile and other support methods, raise awareness of the public to seek help through the different cessation modality, coordinate with each other and at the Ministry of Health national level. And why I am saying this, today you will hear the experience of Qatar in changing the modality to suit better the COVID-19 circumstances. While when you look at the report of the NCD Essential Health Services, you will see that Qatar reported that they didn't include cessation services. So while the NCD focal point report that they didn't include cessation services, we see that they are one of the best countries in cessation services. So that calls for more coordination at national level between different players. The seventh most important point is to continue to monitor the progress that is happening at national level and accommodate and change accordingly. You see the two photos with the health warnings and the number of quit line, and this is one very important and free strategy to promote your quit line at national level. And the above poster is for cessation awareness campaigns, encouraging people to quit tobacco. What can we do? How can WHO help? Of course, this is Florence again, and we don't get enough of Florence in this webinar. I think we encourage and we invite countries attending today to approach WHO with their needs and with what they want to do in cessation. Jointly, we will identify the gaps and the needed support. We will then agree on what kind of support is needed, and we will provide it. we will continue to monitor together and evaluate the situation and modify accordingly. As you can see on the different photos that I included in this slide, these are the training packaging for cessation, and you can see Dongbu presenting. This is one of our cessation trainings in the region, and it is on the global, the package is on the global website, and I put the global website here. And the other photo is also different publications on cessation that are available online in the same, under the same address. So we invite all countries to engage with us. Let us together look at the cessation services and how they, what is their status, and improve it together. Thank you very much. So I think now we move to the fourth speaker in the agenda, and this is Dr. Hiba Fuad. Dr. Hiba, please, you can start your presentation now. I will mute myself, and if you want us to share your screen, please let us know.
Thank you very much, Dr. Fatma. And Sophia, if I can share my screen and let me see that I'm disabled for screen sharing. So if you can put the slide from your side, Sophia, that would be great. Yes, thank you very much. So next slide, please. So can you hear me all?
Yes, Dr. Hiba, we can hear you very well. Please go ahead.
Thank you. So I will start from where Dr. Fatma ended her presentation by advising on the way forward for continuing to monitor. And actually, as Dr. Fatma mentioned in her presentation, monitoring is one of the 6 recommended WHO strategies on demand reduction for tobacco. And we have good news that more than 58% of our population in the region, in 22 countries, are covered by one of the monitoring policies and the highest level as well. So I will start from here, and we'll talk about the importance of monitoring and continuing to track the extent and the character of the tobacco epidemic and indicate how to best implement the policies. And the next slide will focus on, next slide please, on the data coming from the evidence generated among youth from the Global Tobacco Surveillance System. Next slide please. Especially the Global Youth Tobacco Survey and the current smokers who tried to stop smoking in the past 12 months. In all the EMR countries, as you can see, there is a high demand to try to stop smoking and to needed support. This level reaches as high as 70 and 80% in countries. And if we look at the details, these are in Libya, in Syria, in Iraq, and in Yemen, and which means that all countries, whatever the situation or the conflict or the status of the country, the need for the help is very high and the demand is high. Next slide, please. However, on the other hand, if we look at those who are able to have received help from program or a professional to stop smoking among youth 13 to 15 years, is less than half of the demand that we have seen in the previous slide, apart maybe from Lebanon, which is still providing this help as 70 or 80% for males. So these provide the gap that Dongbu actually described between the demand and the need or the met need. Next slide, please. Looking at the adult data, next slide, and the evidence generated from the household survey using the tobacco questions for surveys, which are standard questions extracted from the Global Adult Tobacco Survey as a component from the Global Tobacco Surveillance System. And we can see from here that the current smokers who tried to stop smoking during the past 12 months actually are in a variable levels. We have the example as high as in Afghanistan, reaching above 80%, and it's 60% in Oman, and in Qatar it's about 40%. And this variation means that there are different strategies and different dependence on tobacco and nicotine in the different countries. Of course, the tobacco industry plays an important role behind. Next slide, please. As we can see, the current smokers who were advised by a healthcare provider to stop smoking among adults still is a very low compared to the demand that we have seen in the previous slide. And this has been reaching as low as 20s in some of the countries. However, the countries that have been reported to have the high cessation service like Kuwait and Qatar, we can see that there is a high demand. Next slide, please. So I would like to highlight some of the conclusion remarks based on the evidence and the indicator or comparable indicators that we generated from the youth and adult surveys. Both youth and adults are actually in a need or have a high demand for cessation and the unmet need among both groups. With the COVID-19 lesson, people living with NCDs and NCD risk factors are actually more vulnerable. And we have seen that smokers were at increased risk for COVID infection. And as Dr. Fatma explained in her presentation, the rapid assessment on NCD services, including in the COVID response plan, has reflected that COVID-19 impacted health system, which became overwhelmed by increasing demand for care for people, including cessation as one of the essential services. Next slide, please. So what actually we need to do and what actually we need to think of to strengthen is needed than ever, and in general, to be capable of responding to current and future pandemic. So a resilient health system with a strong and well-resourced healthcare workforce is much needed than ever. The thinking of innovations and shift from on-site to remote consultation might be balancing. However, we need to think of the approach on how to produce the digital healthcare solutions and innovations to support NCDs and NCD risk factors during the pandemic and outbreak as a lesson learned from the COVID-19. And next slide, please. And I would like to highlight one of the examples that Dongbu also referred to, and we have a good example from our region who implemented the Be Healthy, Be Mobile initiative, which helps governments to design and integrate digital health services into existing health systems with many programs. And one of those programs is Cessation. And in our region, Tunisia has led the experiment and the pilot of the Cessation program successfully. And definitely we have participants from Tunisia who can maybe provide some example and insight about the success of such initiative. So I will stop here and leave the floor to other participants and other speakers, and thank you very much.
Thank you very much, Dr. Hiba, for your very informative presentation. And as we can see from Dr. Hiba, there is high demand for cessation even before COVID. And now with the ban of water pipe and strengthening the ban of tobacco use in public places, I am sure that the demand for cessation services will increase in the region. And that's why we need to adjust our services and our capacity at national level accordingly. We move now to one of the most successful examples of cessation services in the region. We move to Dr. Ahmed Al-Mulla from Qatar, who will present to us the situation of cessation services in Qatar and how was it modified to better serve the public during COVID-19. Over to you, Dr. Ahmed.
For everybody, I am happy. Thank you for you and your colleague in WHO, Fatma. You hear me? Hello?
Yes, Dr. Ahmed, we hear you very well. Please go ahead.
That's great. Thank you for you, Fatma, for this organizing this very important topic and your colleague in WHO. And I'm very happy with your all my colleague, brother and sister, actually. Lovely group. In this short time, actually, okay. In this short time, I'll be trying to cover as much as I can about the service which we work in it during COVID time, from shift of the scope of the work and how what's the approach we use it and the impact of this approach and the service and other clinical support related services and the health awareness we use it or we cover it during the COVID and the research topic which we work and we call in this time. Okay. in response to the COVID-19 pandemic and in alignment with the Mohammed Medical Corporation precautionary measure to limit the spread of the virus, HMC Tobacco Control Center, WHO Collaborative Center, we made a drastic shift in the scope of the work to meet the need of the general population, particularly smoker and the tobacco user actually. We see that if we stop the surface, it's really very difficult for our patient actually, especially a lot of the patient become aware of the important or relation between the smoking and the virus and the entry of the virus from the respiratory system and the effect of the smoking and the immunity of the patient who smoke in relation to COVID. So we try to shift the surface from face-to-face consultation to telephone consultation and virtual or video consultation. We try both actually in the beginning, but we find video or virtual is not accepted a lot by the patient. So we concentrate on telephone consultation, and Qatar was the first country in the region that adopted telemedicine approach to continue provide provision of smoking cessation service. So that's instead of stop the service, we find an alternative which works very good with the patient actually. So what the approach we use it, we try to keep everything as if in general, as if in like before actually. So we have like a three clinic or three site to provide the service. We have the main center here, and we have a clinic in Hamad General Hospital, and we have another clinic on Al Wakra Hospital. So close the two clinic in Hamad Hospital and the Al Wakra two location, close it, bring all the staff in the center to work from the center actually, provide all similarity surface like before. So before, usually when the patient came to the center, he responsible to fill the assessment form. So he's not since he's not available and present by himself, so our nurse or health educator contact the patient initially to fill the assessment form, which include, I mean, his socio-demographic data, health data, all the relation issue for him. Everything we did him for assessment, except we didn't measure carbon monoxide. We try to avoid to measure carbon, not to measure carbon monoxide actually in this time. So after the full assessment, he transferred to the smoking cessation specialist, our doctor, who go in depth counseling with him actually and assess they willing to quit and put up the plan why he want to quit the smoking and to find the best treatment available for him according to the number of the cigarette, kind of the tobacco he use it, and the health condition. So prescription of the medication for the patient at the end of the sitting, and he will be referred again back to the receptionist to contact him, to give him appointment either within 2 to 3 weeks to follow up. After he finished that, we also, our psychologist call him back to do behavioral modification guidelines. So all the psychologists, especially for a new patient actually, to give all possible support. So we cover assessment, we cover smoking cessation counseling, and again, psychological support for him. Okay, why I go back? Okay, so the impact of the approach was very positive, as the clinical witness the following: decrease in the waiting list actually. Before we have long waiting list, since we opened the clinic all 7 days, all the center, all the doctor, like 4 clinic per day we have it in the center. That's decrease in waiting time. And the good thing also decrease in the show rate. Before the patient have to come to the hospital, find the parking, go to the doctor, go to the pharmacy, take a long time from them actually. By this approach, we find that decrease in the show rate, almost 99%, more than 90%, all the patient available during when we call him actually a response to our call. Also an increase in patient, as we mentioned, an increase in the patient engagement and the response rate, which is full of our instruction, because we give him another telephone hotline to call us anytime if he need anything. Also an increase in patient satisfaction about the level. All the response we get it from our patient, they are happy with the service, and they wish if that continues the same service later after the COVID actually. Also, we provide another clinical related support service. We establish a 24-hour, 7 days hotline service. Thus, all the patients, they can send a message if they need it, or the call, doctor on call, who have the telephone with him to answer the telephone actually, and they give him guidelines and the support. Also, the other thing, we did it for him, like one of the service of Hamad Medical Corporation, we home delivery of prescribed medication. He have to call, he didn't have to come to the, also to the hospital or to the pharmacy to take his medication. He have to call one specific number, we have it 16,000, and give him home address, and within 24 days, next day, they deliver the medication for him. So that is good service. He is happy a lot with this service. Also, as an increase of the number of the operation clinic, per day, per week, from 2 clinic or 3 clinic in the center, we work 7 days from Sunday to Thursday, full day clinic actually, compared to, because that we have noticeable increase in appointment request. So per day, we see more than 80 patients every day actually between the new and the follow-up patient. Also, other activity we did it from health awareness and the promotion activity. WhatsApp group were created to circulate all awareness message on the tip to all the smoker previously on the new patient to attend the center. This will be served as a gateway for the being spread among the wider of the community. Also, awareness message have been displayed on all the social media from Twitter to Instagram in support of the media of the Hamad and the other general media from our follower. Also, local radio station, TV channel like Qatar TV, Al Jazeera TV, hosted our specialist to spread the awareness, to re-emphasize the importance of the quitting of the smoking, especially during the COVID. Arabic and English also newspaper was being used actually to cover the important role of the center play in the fight against tobacco, particularly at the time of the COVID-19. And the good thing, when we send a message or social media, TV, we notice after a few hours, a lot of people start to call, they need the service actually. With this, that's very positive, encourage us to work more and more hard. This kind of shape of the awareness or activity we use it during the COVID in newspaper, Arabic and English newspaper, social media, all this actually activity. Also on the research, we find this is a very good opportunity to work in the research to find if there is a relation between the tobacco use or electronic cigarette and severity of the COVID. So we didn't miss this opportunity, and we submit our research to our research center, and we get it able to succeed and get it funded from them to conduct this research. And the aim of the study was examine the possible relationship between the COVID-19 and tobacco or electronic cigarette used during the ongoing pandemic. And the objective of the study was test the possible relationship between the tobacco and or electronic.
Dr. Ahmed? Dr. Ahmed, we cannot hear you. Dr. Ahmed, was you muted?
Okay, now?
Yes, we can hear you now. Please go ahead.
Sorry, almost the last 2 slides. The objective, I mean, to this, the possible relation. You heard me from the beginning of the research, or shall I repeat it?
Please repeat it.
Okay, I mean, we find also it's a good opportunity during research time in this research COVID, not to do some good research to support our center, support WHO actually in this work, to assist to find if there is association between the tobacco and or electronic cigarette use during the COVID time. So we submit our research to our medical research center in Hamad to get fund, and they approve for us actually the research. So the study was examine the possible relationship between the COVID-19 and the tobacco and or electronic use during the ongoing pandemic. Objective of that, to test the possible relationship between the tobacco and or electronic cigarette use during and the severity of the COVID-19. To determine the percentage of different types of tobacco and or electronic cigarette use among COVID-19 positive patients in Qatar. Identify and quantify the risk factor for severe disease progression among COVID-19 positive patients in Qatar. Not work. Why it is not working? Okay. The methodology used, I mean, it is cross-sectional descriptive study based on the telephone-based survey among confirmed COVID cases patient in Qatar. And the sample size we get it is about over 10,000 positive patients who will be 18 years old and above will be contacted actually. Research project is still ongoing. We are covered almost 40% of the calling of the patient. For the died patient, actually, will be go through the Cerner or electronic system and medical record to find if we can get it information from those death patient, or will be contact also the family or friend who live with him to get the information needed to find if there is possibility also between the death cases and the severity, or if they are very smoker. The way forward in the conclusion, actually, the HMC Tobacco Center, which is our WHO Collaborative Center, serve as the hub for smoking cessation and tobacco control, as well as comprehensive training healthcare professional, not only in the state Qatar also, but on the region, on the Emiri region and the African region. And this will be happened by support of our colleague from Dr. Dunbu and Dr. Firas. Both of them, we are with a team working very hard actually on the support of WHO. The center will be continuing with the strive and the work collectively with the different local and the regional stakeholders to combat the fight against tobacco. And finally, also with a positive noticeable impact, as Dr. Hibat mentioned, of the adopted telemedicine approach during the pandemic, the center aimed to implementation this in the future actually. This will be mainly, we think, to bring the new patient actually to the center, and for follow-up, first or second or third follow-up, we'll be doing it through the phone, and we can bring the patient during the last visit also. The important actually to get the patient in the face-to-face at the first time, we can do all the measure carbon monoxide level for him, measure his weight, and to get his BMI. All this will be important, and one visit also at the end of when he stops smoking. But during the two, in the beginning and the end of the last visit, we'll be using the telephone contact patient actually, telephone method way. That will be help the patient to adhere to our need, reduce the time for him to leave the work, to go to the Hamad hospital, to the center, to take the medication. All this will be fine. It's very important for us actually. Also, we adapted laser treatment at the center. Those patients, they have to come to the center, but we minimize the number who came to the center per day, not more than 6 to 8 patients, to reduce the risk of the spread of infection between the patient. All this form or modality work with us very good actually, and we help also our patient, and we hope that other countries will follow this actually, not to stop service, but find different way to give center service for the patient, for the other patient. Thank you very much for you, and I hope this will be beneficial for all of us.
Thank you very much, Dr. Ahmed Al-Mulla from Qatar, for this very important presentation. And I take this chance to highlight that the center in Qatar is a global center. So it serves all countries, and it can receive requests from different countries of the region. This is a WHO collaborating center that focuses on cessation. And currently we are in negotiations with the Islamic Republic of Iran, Dr. Ghulam Reza Haidari, to establish another collaborating center in Iran for cessation services and other tobacco control issues as well. With the existing of the Qatar Cessation Center, we encourage countries to approach the center, and together with WHO, we can plan together the support for different countries based on their requests. And also, once the Iranian center is established, it will become a regional also center that can support countries in their different activities. Thank you very much, Dr. Ahmed, once more. And now we move to our final presentation. Dr. Firas Hawari, one of the most important regional experts and global experts in the area of tobacco control, has trained so many countries in the region, has access to many services, and was engaged in evaluating cessation services in different countries of the region. Over to you, Dr. Firas.
Good morning, all, and I hope you can hear me well. I'm going to try and share my screen with you.
It is working.
Okay, perfect.
It's working, and we can hear you well.
Okay, perfect. Thank you so much, Dr. Fatma, and everybody. It's nice to hear your voices during these very difficult times, and I hope we can soon start meeting again. I'm going to go quickly through some of the challenges that we are facing in the region based on our experience. Despite having a clear effect for cessation services and treatment, as you can see, that can outweighs the effect and the benefits of an effective prevention. Despite all that, cessation services have been slow in terms of growing in the region and in terms of incorporating those services into the healthcare sector. Some of the challenges really stem from multiple things, as I can show you in this slide and then discuss in details here. One of the most important challenges that we have, and it's slowing really the growth of the cessation services, is the poor implementation of the FCTC agreement, where prevention and treatment should really go hand in hand. And that if we look at the FCTC and the WHO strategies for tobacco control, we can see that those strategies can only succeed fully if they are integrated and implemented together. And as you can see from all these strategies, eventually when implemented, they will feed into the O, or the offer to help in quitting. As you can see, even whether it's raising taxes, enforcing the bans, the warning, in the end, if we are successful in implementing these strategies, will all drive the demand for quitting cessation or for smoking cessation and quitting smoking in the end, which means that we have to go hand in hand and also provide those services. Otherwise, we will lose the benefit of the Empower strategy. Offering help to quit is really based on providing easily accessible services to manage tobacco dependence clinically at 100% of primary healthcare facilities and through community resources. So the concept of having only cessation clinics is probably one of the factors that might interfere with the spread of the cessation services across a nation. And we need to think about that. It would be nice to have those cessation clinics in centers that are specific for non-communicable diseases, such as heart centers, lung centers, or cancer centers. But in the end, we must integrate those services across the healthcare system. Some of the personal challenges that we have is the strong addictive power of smoking, which really put a lot of denial in the mind of those who smoke, and also fear of losing control. This loss of control can be due to mental or physical. You can see mood changes, you can see body changes in terms of gaining weight. All this would contribute to resisting or being hesitant in approaching the cessation services. In addition, there's a lot of social pressures. Former smokers who quit without formal assistance may always spread the myth. And that myth is unfortunately being also spread among officials who are in charge of implementing the FCTC agreement, who we still have not gained their trust that cessation is an effective medical treatment that must be implemented. So unfortunately, this myth is being spread by those rare cases who manage to quit on their own, which is about 3 to 5%, as Dr. Fu mentioned, and also myths about the best way to quit smoking, and that is cold turkey. And again, people who succeed in quitting cold turkey are only the minority of subjects, and most of the time we need to have medical help and pharmacological treatment and behavioral therapy in order to succeed. We face also the industry factor, which is really an important factor. The promotion from the industry is really much stronger than the promotion for healthcare services relevant to smoking cessation. And of course, it is more attractive and they are more artistic in doing that, something that we always need to keep in mind when we are trying to promote our services. In addition, the industry is promoting other gateway products for cigarette smoking, such as water pipe, e-cigarettes, and many, many novel products, the IQOS, and I'm sure they have more in the pipeline, which is representing a real threat, not just for cessation, but also tobacco control in general. Our treatment methods have been really behind when you compare to the methods the tobacco industry is developing continuously and that promotes the addiction. So we can see that we are still lagging in our engineering capacity in delivering nicotine appropriately when you compare that to cigarette smoking, where they add so many additives and maximize the addiction and the delivery of nicotine to the brain. We have also other factors such as group counseling, which might not be very acceptable in our part of the world, where the patient is really hesitant to tell the story to more than one person. In addition, the stigma of being referred to a psychiatrist or a psychologist would also have a negative impact on cessation in general. The financial barriers are real. We have the industry manipulating the prices, making them available, making cigarettes available for very inexpensive prices, while our medications are usually very expensive and not easy to access. And we can see that the insurance also companies are not being supportive in terms of covering the healthcare costs of smoking cessation. Staff attitudes and tobacco use, I think this is one of the most dangerous obstacles that we have. Up to 40% of addiction treatment staff are tobacco dependent. By the way, those numbers are improving in the West, but they are still significant. So don't count on this as just as part of our region. An additional major factor is the lack of training. I think one of the things that we can come out with from this webinar is how to better improve training capacities for our staff, the lack of benefit of treatment from our staff, which is also because of lack of education and other factors, and also the lack of financial compensation for the time of medical staff who are investing really significant time. So we spend 3 times with a new patient for smoking cessation than the amount of time that we spend for a pulmonary disease patient, and still the compensation is less. As you can see here from our own data, there is significant lack of competencies among medical staff, and those competencies has significantly improved across the board, as you can see, with continuous training. There are many challenges that happened with us during the COVID-19, where smoking cessation, of course, fell off the priority list. New patients stopped because of the lockdown. We had severe lockdown in Jordan, where you can really only go out to buy your grocery and come back. That hampered our efforts, and in fact, patients relapsed and started to consume more cigarettes because of the time they spent at home with nothing to do. One of the things that we are trying to do right now, and we are successful, I would say, that we have switched our very popular tobacco treatment specialist training program to an online course, and it will be delivered, inshallah, end of October this year. If anybody is interested in becoming certified as a tobacco treatment specialist, they can go on the website for King Hussein Cancer Center and register for our online treatment course. This would be our first online course. Thank you again for this opportunity, and I hope that we can push cessation services better in our region. Thank you very much.
Thank you very much, Dr. Firas. We actually shared the information on the course that Dr. Firas mentioned with all the countries, and please, we encourage you to participate in it. Unfortunately, we don't have financial support for the course, but maybe at national level you can find the suitable resources to enroll in this course. This is the first regional online course on cessation services that is organized by Dr. Firas and his team. We completed the set of presentations in this webinar, and we now will move to the questions and answer sessions. We exceeded the time of the webinar with 8 minutes, so let us have only 15 minutes for the questions and answers. Dr. Randa is with us, and she will moderate this session. May I kindly, before handing to Dr. Randa, ask all the presenters when they answer the questions to be very brief, and to the point, so that we don't exceed the 15 minutes. As I see that we are starting to lose participants already. We had 67 participants, and now as we completed an hour, participants started to leave the webinar. So we need to make sure that we don't exceed the 15 minutes for the session. Over to you, Dr. Randa, for the sessions of questions and answers.
Thank you very much, Dr. Fatima, for inviting me. And because we are short of time, I'll go directly into the question. Of course, I thank all the distinguished speakers for their insightful presentations, but I have some of the interesting questions, and others will need a lot of clarification. Let me start with a question from my dear colleague, Dr. Jawad Al-Lawati. He was asking, and I think this question will go to you, Dr. Fatima. Could you explain why Pakistan is the best in tobacco cessation, yet later you said UAE and Saudi Arabia and Kuwait have the best services? Over to you, Dr. Fatima.
Thank you, Dr. Jawad. No, Pakistan is not the best in cessation services. Pakistan is the only country that will achieve the target of 30% reduction in tobacco prevalence by the year 2025. The three countries that I mentioned are the best in cessation services because they met all the requirements of integration into primary health care, of having a quick line, and of providing nicotine replacement therapy for the public. So this is the issue. Pakistan is very strong in policies like tobacco-free public places, like graphic health warnings, like other policies, but they are until today not the best in cessation. Over to you, Dr. Randa.
Thanks, Dr. Fatima. Now we have a question from Pakistan, from Dr. Shahzad Khan. He's asking, and I think, please, Dr. Dongbu, to elaborate on this, if there is any country globally, or countries, of course, that has implemented the cessation services at the primary healthcare level. Please, Dongbu.
Yes. Yes, I think first I think I understand every country more or less have cessation support in the primary care level. For example, the primary care providers will always try to advise the patients who use tobacco to quit. But the situation is only around 50% of doctors or primary providers are routinely doing that. So I want to say there is one country have no cessation support in primary care level. It means the level of delivery or the provision. So I can only share you say many countries actually have cessation support in most primary care facilities with the cost coverage. Okay. One example is New Zealand. Another example is United Kingdom. For low and middle income country, we also have several countries did a very good job. For example, Brazil. So I just give you some country name, but we have like every 2 years a global report actually have a detailed information about what kind of cessation support in the primary care level. This can be also available from our website as well. Yeah, I stop here if I answer clearly.
Thanks, Dongbu, and please, this another question. I think you will be.
This one.
Yes, please, Dongbu. They were Mansoor Ranjbar were asking about the effectiveness and evaluation for the Florence system. What about it, and if it is in progress?
Okay. Florence is, as I'm, because time is very limited, I only describe it, is a WHO digital health worker. It means it's designed to mimic what a primary care provider usually do in very busy primary care setting. It's provide 3 to 5 minutes brief advice. The effectiveness or efficacy of brief advice is around 2%. This is in addition to there's 4% quitting rate without support. Adding this 2%, you say if somebody receive a brief advice, they will have around 6% of success quit rate lifetime. This is the synthesized evidence to show. But in many countries, because many people have never received any support, the quit rate can be even much higher, like 30%, 40%. The Florence exactly play a role as a primary care provider, but because this COVID-19 pandemic, because the disruption of the primary care level, many people have no access to tobacco support through the primary care level. So they can actually speak with Florence. So Florence acts as a gateway to provide brief advice and then refer to the existing digital cessation services. We are in the process of evaluation of this tool. This moment we have no data to share with you, but we believe can achieve the same effectiveness of the primary care level brief tobacco intervention.
Thank you.
Level.
Thank you very much, Dongbu. And I think the next question, please, Dr. Fatima, to elaborate on this because it was repeated twice from both dear colleague Raouf and from Dr. Wasim Al-Kailani too. They were asking about to elaborate on the industry about the heated tobacco products and cessation tools and the new decision from the FDA regarding the IQOS, that the conflict made because of this new decision, and the industry claims spreading that this is one of the tools to be used. Would you please elaborate on this?
Thank you very much, Rhonda, and I will be quick. But I ask you first to look at your WhatsApp because I just sent you a message.
Okay.
On the FDA question, this is a very important question. Thank you very much. Of course, it created a lot of confusion at the national level, and we received lots of questions from our member states. WHO had issued a statement on this, followed by a statement by the FCTC. I ask all colleagues to look at it, but in summary, it is saying that this doesn't indicate it is safe. There is no enough evidence that this is a cessation tool, and I take this opportunity to encourage all the colleagues to be very careful when the claim comes from the industry on new products as cessation tools. WHO still insists that the cessation tools are the known cessation tools, the traditional cessation tools, and the electronic cigarette, the heated tobacco, including the IQOS, are not recognized cessation tools for tobacco use until this moment. So please take the claims of the tobacco industry very carefully. And also, I think there is a call for a review of the position of FDA by many scientists in the United States. Please have a look at the statement of WHO. We also shared it by email with all the countries. Anybody who needs access to it can send us, and we will share the link to it, the WHO statement and the FCTC statement. Over to you.
Thank you very much, Dr. Fatima. And dear Dr. Asmus, I would like to direct this question to you, if you may allow to respond to it. The question is coming from Zahir Al-Ankoudi. Do you think that one of the reasons of not expanding the service of the cessation service is that some of the WHO EMRO members, representing members, are not with the tobacco cessation? Over to you, Dr. Asmus.
Thank you very much for this interesting thought and interesting question. And I think there's no straight answer to that, because obviously membership to the convention is one important political commitment, but it doesn't, not being a member doesn't preclude a country from not taking the right action. So I think there's not a direct correlation necessarily, especially when it comes to action in decentralized health facilities. But naturally and clearly, the WHO system overall is very much encouraging the adoption and the ratification of the FC protocol. Maybe Fatima, you would like to add some additional detail to this response. Thank you.
Thank you very much, Dr. Asmus. Actually, I cannot agree more with what Dr. Asmus just said. There is no straight answer for it. While the cessation services is one of the most simple policies that WHO is recommending for effective impact on the prevalence. But unfortunately, we are not seeing progress in it since the year 2008 when we started collecting information on the Empower implementation. We take this chance to encourage all countries to look critically at their services and make sure that they have adequate elements to make sure that they move into to the top level of this policy. One of the key challenges is the quit line and the resources for it. I think partnership with private sector can facilitate this. It all depends on the situation at the country level. Thank you very much. Over to you.
Thank you, Dr. Fatima. Dear Dr. Ahmed Al-Molla, I think this question you will be the best to answer from your perfect experience in this regard. Nadim Dawood is asking, who could be trained to provide the service? Is it mandatory to have health background? Would you please elaborate on this?
Yes. It's not necessary, but is more acceptable from patient from our experience, which we training now. We train actually the physician, nurse, pharmacist. That's which we concentrated on our training. But that's also acceptable and maybe not in our region. Other health worker actually it could be deliver even short using 5 A's to encourage patient or directly the patient to get the service actually during any health service. Is important. Why health service? Because that's where the patient contact came to you. That's not meaning not engaging other people in the community. Actually, we have a lot of the people who stopped smoking before and they're willing to volunteer with us to deliver our message, encourage other people smoker in the area. Actually, many people, he said, I want to work with you. He go to for a smoker, give him short what he get experience when he quit smoking actually. But to be in a proper way of the delivering of this service, it should be, or my experience, to be a health worker actually, which would be also acceptable from our people, from nursing, doctors, and pharmacists, or other health-related worker. That's my experience. Also, I would like to comment on the question related from our brother from Pakistan related to the primary healthcare providing smoking cessation. In Qatar, we have almost more than 12 of our primary healthcare services. They have clinic in the primary healthcare delivering smoking cessation services, working with us actually. So we have the center, and also in most of the health center in the Qatari, they have smoking cessation. Thank you.
Thank you, Dr. Ahmed, very much for your clarification. And dear Heba, I think you will be the most convenient to answer a question about from Wasim El-Bayati. What are the updated researches regarding the relationship between COVID-19 and smoking?
Well, this is a very important question. However, we are now doing such kind of rapid assessments that actually help us explore more about the cessation services and other NCD services that is integrated in the COVID response plans. So based on the assessment that has been done so far in general, we have seen that cessation is one of the less integrated in terms of essential health services in the COVID response plans. We are still looking into the details of the plans that provided by countries and submitted in the rapid assessment survey that we have done on NCDs. We can also help countries in doing other assessment in relation to smoking and tobacco control measures during and after COVID-19. And I think Tobacco Free Initiative team is leading such activity with some countries now. So I think the research is ongoing and many countries have done, and Dr. Ahmed Al-Molla have elaborated more in his presentation on some of the relationships. So we're still in the making, and soon many data will come out. And of course, we are also integrating some of the questions related to the COVID-19 in the STEPS protocol and household surveys. So all of these are in consideration, and the standard comparable indicators will be developed so that countries can benefit out of it when they implement their surveys and surveillance system. Thank you.
Thank you, dear. I think the next question will be the last one because of the timeline of the WebEx, and I would like to direct it to Dr. Fras, coming from Amal. In what ways cessation advice or service differ between traditional and electronic products, if there is actually a difference between both?
I'm not sure I understand the question, but electronic products, does that mean electronic cigarettes? Or I don't think I understand the question, but definitely, I mean, the traditional ways of smoking cessation are the approved ways, which include the behavioral therapy, motivational interviewing, and pharmacological therapy. Brief advice is definitely on board, and it is effective. And it has to be complemented always by a site to be to refer patients to. I don't know if I answered the question or not.
Yes, please, Dr. Faras, a last question directed to you specifically to respond to is about the cost. Establishing cessation services is one of the main obstacles to establish it is the high cost for this service. What can be done to overcome this problem? Over to you, Doctor.
I think at this point, we have to put a pressure, all of us, including WHO, on insurance plans so that they can start covering this as a non-communicable disease or as a similar to what we do with other addictions, whether it's alcohol, drugs. Until we get that built in within our insurance plans and our insurance companies, the cost is going to continue to be high, and immediate transitional solutions such as donations or availing the drugs for a short period of time would actually might be harmful rather than helpful, because it would spread among smokers that this service is not really consistent over time. So I think all of us would need to start putting pressure on insurance plans, whether it's governmental or private, to cover the service.
Thank you very much, Dr. Faras. I think we have to stop here because it's almost half an hour past 11. And I would like to thank all participants for joining us and for your time and for the valuable contribution and expertise of the distinguished speakers. Over to you, Dr. Fatima, if you would like to close and wrap up.
Thank you very much, Dr. Randa. Thank you all speakers. Thank you all participants for joining us and for staying for 1.5 hours with us. I think there are 4 main conclusions of this webinar, taking the discussions and the presentations. Countries are indeed encouraged to approach WHO and its collaborating centers for planning jointly the needed support to strengthen cessation services with COVID or without COVID, but we need to have a comprehensive approach to our cessation services at national level. The new claims by the tobacco industry must be taken very carefully and examined very carefully and still take into account the recommendations of WHO and FCTC for using only the proven methods for cessation services and cessation and quitting of tobacco. There is a need for increased training capacity of health professionals in the regions and the other professionals who can support the cessation services at national level. And I think this is something that countries need to discuss with us. There is a need to take into account the cessation and mobile cessation services and encourage countries to apply it as part of their comprehensive approach for cessation. I thank you all very much. I think with these 4 conclusions, we close this webinar, and we will be sending you the presentation, all the presentations through a link that will be shared by my colleague, Ms. Radwa El-Wakil, and we also will send the 4 outcome with all countries through email. Again, thank you very much, and I wish you a very fruitful rest of the day. Thank you.
Thank you very
Dr.
much.
Asmus, would you like to conclude with the word for the participants?
No, this is excellent. Thank you so much. And I'm really grateful for the interest and the contributions from the countries, but also the involvement of our country office colleagues, our headquarter colleagues, of course. And I just hope that we can jointly harness the challenges, but also opportunities of these exceptional times and move forward the important tobacco control agenda, especially in the area of cessation. Thank you so much, everyone.
Thank you, Dr. Asmus. Thank you, everybody. And inshallah, we continue our collaboration in this area. Thank you.
Thank you.
Thank you very much.